doing really good. So just keep up your practicing, keep up your studying on those contras. Don't forget those contras. We had a few people that forgot contras on the skill comps, but we kind of gave you a hint. So, but don't expect that hint this time. We may or may not give it to you. Okay, so today we're going to start on totally new things. Yes. Somebody call me? Oh, I thought somebody said my name, sorry. We're going to start on a totally different set of modalities today, electrical modalities. And these are things that that everybody usually has a good time with, that likes and that enjoys this. Somebody just sent me a question. Are we going to go over exam 2? We will be able to go over exam 2. We will have to do it after class. So if y'all want to go over it after class today, what time do y'all get out of class today? Is it 12 or 12:30?
12.
12. Okay, so if y'all want, at 12:15 I'll open this room back up, and if anybody that wants to go over exam 2, we can go over exam 2. Okay, so it's not mandatory, but if you want to, you can come to that. Okay, does that sound good? I guess so. Okay, so let's go ahead and get started on our electrical modalities. So let me go ahead and give you a rundown of what we're going to be doing this morning. It's going to be kind of a long morning. We've got 3 PowerPoints to go over. So if you're looking in Blackboard, the first one we're going to go over should just be called electrical currents general or something like that. And then we're going to go over another one called interferential, or IFC, and I think it's labeled IFC in your in course content. And then we're going to go over TENS, which is TENS, and it's all caps. It stands for something. So we're going to go over those. So the first PowerPoint is about just general electrical currents. Is a little long, so we've got to get through it. But we've got to get through that to understand the rest of what we're going to be talking about, okay? All right. And then we won't have, and obviously because this Wednesday is practicals, we won't have time to practice these modalities on Wednesday. But if you want to come in on Open Lab on Friday, we could do that then, or but we'll definitely be going over them the next week, okay? Okay, so let me bring up the first PowerPoint. And I am recording this. Okay, electrical currents. Okay, so I just an introduction. We went through this back in Intro to PT back last semester. Electrical currents have been used in medicine and in rehab all the way back to thousands of years ago. 46 AD is the first time it was ever used, and they used electrical fish to alleviate pain, especially headaches. Now, I don't know the procedure of doing that, and who knows if it actually worked, but that is the first documentation documented in history of electrical currents being used in medicine. So a long time ago, even before we had electricity. So in about 1791, there was a scientist that was named Galvani. And you'll hear that name again because you'll hear the name galvanic current. He was a researcher, and he, and I don't know why he got this, who knows why he got this idea, but he took a frog or several frogs, and he dissected them down to the muscles. He took the skin away, and then he would touch different electrical currents to them through some kind of conductor. And he would notice that touching the dead frog's muscle to an electrical current would always make the muscle contract, just like if the frog was still alive. But these frogs were obviously dead because he had dissected them. Well, he used that, and this other scientist came along later and called those locations motor points. So motor points, you will hear that again. Every muscle in the body that we can do electrical stimulation on has a motor point. And the motor point is just simply the place of the muscle that is most sensitive to the electrical current and will contract with that current, or will feel less pain with that current. Now, everybody's motor points are generally about the same, but there's a little difference between everybody, especially in the lower leg. So when we start practicing this, you all will make sure you practice on more than one person, because you'll see that people have slightly different motor points. So then we started using electricity for pain control. And so when they developed the gate control theory, which we've went over before in the 1960s, about that same time, they were experimenting with electrical stimulation to help with pain, and found that it did help with pain. So you can use what we're going to be talking about today in this first PowerPoint is mostly pain, but we just know that we're going to learn electrical stimulation for pain control and for strengthening, for motor stimulation, for muscle stimulation. But for right now, we're just talking about both. Okay, so what can we do with electrical stimulation? Like I said, muscle strengthening and pain control. We can also use it to heal wounds. And that word recalcitrant, that means wounds that are not healing on their own properly. So this would be if a nurse did electrical stimulation to a wound, or if you as a PTA did electrical stimulation to a wound, it would be a wound that has been long standing and is just not healing on its own. Sometimes you can use it for resolution of edema, but usually there's much easier ways to do that than using electrical stim. There's different ways it can be applied to the body. It can be the most general way and the most common way, and the way that we in our field do it, is by an electrode and an external stimulator, just a little unit that's about the size of a smartphone or a little bigger, and it's got wires from it, and it's attached to sticky pads, and those sticky pads are what we put on the patient on their skin, and that sticky pad has carbon in it, and that's what allows the electricity to be conducted down into the body. Okay, now there are stimulators that are transplanted inside of the body. Now those wouldn't be for muscle stimulation. Those would be likely for chronic pain control. Like if somebody has a very chronic pain condition and it's causing them a lot of pain, excuse me, they could get a pain stimulator implanted in their body that would deliver constant stimulation to them to help with their pain. If it was a pain that has not been resolved by other methods, such as many medication trials, using the surface stimulators, like I was just talking about with the sticky pads, things like that. When those things don't work, then they may try a stimulator. There's also bone stimulators that can be put in the body, such after like a spinal injury. If the spine needs to be stimulated to heal faster and heal as fast as they can, they might implant a bone stimulator in you. But we're not going to be dealing with this. Okay, so these are all some things we're going to go over in the next few slides. And most of these are things I will tell you the ones that you need to know. You need to know really almost all of them, but I'll tell you the ones that you need to pay attention to most importantly. Okay, so let's start with, y'all know how this is just going over, this is just a slide that goes over the nerve depolarization, what happens during an action potential. Now, y'all have had this before, so I'm not going to read through this again, but you are going to be held accountable for it on test. But just know that you've had this before, so I'm going to skip past this real quick. But electrical, what electrical modalities do is they do cause an action potential. So what they do is the electricity is conducted down into the body, and then a nerve picks it up, and then the nerve is going to transmit that electricity just like any other action potential. Because when you think about it, an action potential, all it is just an electrical current. So it's no different than what we're putting in the body. Okay, y'all know about the refractory period with nerve depolarization. So I'll skip past that. Okay, and we'll go over this real quick. This is just the refractory period that you have after you have a muscle contraction. So if we were doing electrical stim for muscle contraction, this first big red wave would be the electricity and the muscle contracting. And then after this would be the refractory period. This would be when the muscle can't contract anymore. Okay, now let's keep going. So in order to in order to reach a certain goal with electrical stimulation, whether it's muscle stimulation or whether it's pain reduction, we need a certain, what we call the strength duration curve. And that means that basically means you need to have your settings just right. And we'll go over the settings later, okay? But just remember that the amount of electrical current required to produce an action potential in different types of nerves is going to vary. So if you're wanting electrical stimulation for pain reduction, you're not going to use as much electricity as if you would if you wanted a muscle contraction. A muscle contraction would need much more electricity. So that's really all the strength duration curve means, is that depending on your goal of therapy is how much the strength of your current will be and how long you'll leave the current on. And we're going to go over all these settings in a minute, don't worry. Another example of that would be if you were doing muscle stimulation to the bicep, it would be less stimulation than if you were stimulating the quads, because the quads are a much bigger muscle. The quads need more stimulation in order to contract and extend the knee, because it's a much bigger muscle and it's got to extend the lower leg. So, and it's a much bigger muscle than the bicep muscle. So it would need more, the quad would need more electricity. That's basically all this means. Down here, it's still part of the strength duration curve. When you let's look at the bottom bullet where it says motor stimulation, that will be longer pulses of electricity and higher amplitudes. And when I say amplitudes, that just means the power that you turn up on the machine. So on different machines, it will be different units, but it's basically just going to go 1 through 4 or 1 through 5 or 1 through 6. That'll be your power level. Okay. So motor stimulation needs they need the electricity to be on longer and then higher amounts of it. For pain control, where this says sensory stimulation, that's what we mean by pain control. On that, since we need less electricity, we're not making a muscle contract, we need shorter pulses of electricity and lower amplitude. So we wouldn't have as much electricity on. Does that make sense? Pretty self-explanatory. Okay, and y'all remember, I know this is all new to y'all, so stop me at any time to ask me questions. Now this is obviously nothing I want you to memorize, but this is just a picture of different nerve fibers and the different just the different amounts of electricity it would take to stimulate them. But this is just for your reference if you want to look at it, if you need to help if you need help understanding it, but by no means am I going to test you on this slide. Here comes action potential again. Okay, let's skip the first half of the slide, but let's talk about the second slide, the second half. And this is still kind of review for y'all, but remember that action potentials are going to travel faster in larger nerves that have myelin around them than the smaller nerves that don't have myelin. So remember, if you remember this back from the very beginning of this semester, we learned that of all the different nerve fibers, it really doesn't matter what type of fiber we're talking about. The ones that have a myelin coating around them, the action potentials are always going to travel a lot faster. Always remember that. And unmyelinated nerve fibers will always carry the action potential slower. And larger nerves are going to think of it as an electrical cord, like a power cord. A larger nerve is going to carry action potentials faster than a smaller nerve. And if you remember saltatory conduction, and I think I have a picture of that here next, this is saltatory conduction, and this is where the action potential is so strong, it's not even, some of it's going down the whole nerve, but some of it is skipping and is jumping around the myelin, and you can see it jumping from between the gaps of the myelin, and that's called the saltatory conduction. Just remember what that means, just the general what saltatory conduction means. All right, so let's start talking about what happens with electrical currents now. Okay, so muscle depolarization. If you are, one thing we can do with electrical currents is give the stimulation to muscles that don't have any nerve innervation. So somebody that might have like a lower motor neuron injury, like a spinal, or somebody that has a spinal cord injury or a peripheral nerve injury, that they don't have control of their muscles, but they want to keep their muscles, for lack of a better term, bulked up, so that for cosmetic reasons, so that they don't atrophy and lose all of their muscle mass and just look like skin and bones. So some people, especially spinal cord injury people, will do electrical stimulation on some of their lower extremities and sometimes their upper extremities too, to make the muscle contract in order to keep the muscle bulk and the muscle fibers there so that it doesn't atrophy. And that's more for cosmetic reasons. Where this says pulses greater than 10 milliseconds are needed to produce contractions in de-innervated muscle, that just means that you need a longer amount. You need the electricity to be on longer for the between breaks for the muscle to contract. It's going to take more power. That's basically all that says. It's just for de-innervated muscles, just remember it takes more electricity and more time on to make the contraction happen. Okay. Now we'll talk about other kinds of current. So let's talk about the kinds of currents. So let's say most electrical currents that we use are called balanced biphasic currents or biphasic waveforms. That means that the type of current doesn't leave any charge in the tissue, okay? That means that when you turn the electricity off, that there's no charge left in the person's body. Like there's no excessive negative charge or positive charge. And that's usually what you want. And let me see if there, I'm going to come back to the slide, but let me see if there's a picture next. No, there's not. Okay. Now, the other type of current besides biphasic we have are called monophasic currents. These are direct currents as opposed to alternating currents, and they're usually unbalanced. That means that, and we'll look at a slide in a minute, but if you had a chart and you had negative and positive charges on either side of the flat line, when you take the electricity, when you turn the machine off, the person's body will still have some electrical charge built up. So it will either have negative ions built up in that area, or it will have positive ions built up in that area. It really depends on what you were using the machine for, whether you have positive or negative ions built up. But you'll learn that later on. Just to give you an example of what you would use a direct or monophasic current for, if you've ever heard of iontophoresis, this is a way that PTs and PTAs, this is one of the only times that we can use a medication on a patient and apply it. We still have to have a doctor's order, but this is when you put an electrical, it's basically a pad that's an absorbent pad that's hooked up to a battery or to a stimulator. And a person that may have inflammation or pain or bone spurs building up, different medications that are liquid, you soak the spongy electrode with the medication, and then you stick it on the body, okay? Now, you have to know what charge your medication is, if it's got a positive charge or a negative charge. And what you want to do is push that medication down into the skin with the direct monophasic current, okay? So what you're going to do is if your medication on the bottle says it has a positive charge, then you're going to make your machine have a positive electrical charge and push to push the ions down into the skin and push the medications transdermally. Because remember, negative charges, different charges attract, alike charges repel. So if you had a positively charged medication, you would put the medication on the pad, stick the pad on the body over the affected area, and then turn your machine on, and you would use all the same amounts of electricity, and it's not going to be where they can feel it, but it's just going to be a little bit, but you would make your electricity positive so that it would push the medication down through the skin. And if your medication was negative, then you would make your electrical current negative. And we won't check off on iontophoresis, but I can show you the transdermal patches that we have that have a battery in them. Okay, so we're going to go through all of these one by one. We've already went through de-innervated muscle, but we're going to go through all of these one by one. So let's go through innervated muscle first. Innervated muscle just means it's a nerve that has a nerve. It's a muscle that has a nerve connection. Okay. So let's stop a second. So we already talked about de-innervated muscle. So innervated muscle, we would give electrical current to if we wanted to strengthen the muscle. So if somebody has had a stroke or a brain injury or a spinal cord injury or any kind of injury where their muscle is suddenly weak, but they still have the ability, there's still some connection there, you can use the electrical currents on there. You place the pads on their muscle, and it will cause the muscle to contract with you turning up your amplitude. That's a way to get the muscle to get stronger. And what you do, it's also a brain feedback thing, because the brain is sending signals not just to the muscle, but it's sending electricity up to the brain too, saying, hey, this machine is turning this muscle on. So what we do with people, we tell them when they're strengthening a muscle with electricity to contract, or think about, even if they barely have the strength to contract on their own, we tell them, okay, I want you, when this machine comes on and you feel the electricity contracting your muscle, I want you to contract as much as you can with it, just like if the electricity wasn't there, and tighten your muscle as much as you can. Now, the person doing that themselves in conjunction with the electricity is not only going to strengthen the muscle even more, but it's going to help the brain recover too, and help the brain to recover the muscle strength too, because muscle strength is more than just what's going on in your muscle tissue, but it also has to do with the control of what's going on in the brain too. So electricity can work, even though it's down in the periphery of the body, it can work as a biofeedback method too. So we talked about de-innervated muscle, and that's mostly for keeping muscles from atrophying for cosmetic reasons. And it can, people that have a lot of spasms because of their injury, like that's called spasticity, if you learned of that. Sometimes we can put electricity on the de-innervated muscles that are spastic. And what we do, it actually makes them contract even more, but after a while it fatigues them so that they can't contract anymore, and that'll get rid of their spasms. Now, that's not going to get rid of their spasms for good. That's just probably for a few hours or a day or so. The other big reason that we use electrical currents is for pain control, pain modulation. So a lot of you may have used TENS units before, or interferential currents. We're going to talk about both of those today, and start playing with them in lab on Friday, but definitely next Monday. I mean, Friday if you're in lab, but definitely next Wednesday in open lab. I'm sorry, definitely in lab day on Wednesday. I'm all confused now. But we have two different kinds of pain modulation modalities that we use electricity with, and we're going to go over them both today. One is called TENS, T-E-N-S, and what is abbreviated IFC. It stands for interferential current. Both of them work pretty much, they're very, very similar, but they do have some differences. We also use, like I said, for tissue healing, like for wounds that are not healing very well. And the transdermal drug delivery, like I talked about with iontophoresis. So these are the different clinical applications. These are basically your 5 main clinical applications of electrical currents in medicine, at least in our field. I shouldn't say in medicine, because other doctors have different things, but this is what we'll be using it for. Okay, so these are all, this list here, we're going to go through all of these things one by one. This is the list of things that of your parameters that you have to set. Now, you know, you had parameters for ultrasound. You have more parameters to set for your electrical currents. Depending on your machine and depending on what your TENS or IFC, some of this is already preset for you, but for most of our machines, we have it to where you have to do it manually. Now, I am going to make a confession that all of our muscle stimulation machines, you have to set completely manually. And all of our TENS machines, you have to set manually. You have to set all of the parameters manually. Well, they're old machines. Now, the newer machines out on the market that they use in clinics, you don't have to do that. They have it all preset for you, and you just choose the body part and stick the pads on. But you don't have to understand your parameters to do that. So that wouldn't teach you anything if we use those units. So we're going to use the units that make you learn everything, because on the boards and on tests, you do have to know these parameters. So for the boards, you're going to have to know every single one of these parameters listed. So you might as well start learning them now. And on your clinicals, if you go to a clinic that uses machines that everything is preset, just ask if you can use one or practice with one that's not, because you need the practice, I promise. Okay, so let's go through frequency first and talk about what frequency is. That's the next slide. Okay, so frequency is it's also measured in hertz, and it's just the number of cycles or pulses per second. So it means pulses. When we say pulses per second, we mean pulses of electricity. So this means that the electricity is not on continuously, like forever and ever and ever, the whole time the machine is on. The machine is given certain cycles per second. So you can see in the top picture here, this line would represent 1 second. And there's 3 current amplitudes that spike up on that 1 second. So this would be a 3 frequency electrical current wave. The second one, if you look down, also has is 1 second, but it has 9 waves of electricity, 9 pulses. So this has a frequency of 9 hertz or 9 pulses per second. Now you can say cycles per second, you can say pulses per second, you can say hertz. You're going to hear all of those used interchangeably, and I don't want to confuse you. And it's not me trying to use them interchangeably, but people use them interchangeably. So some people are going to say hertz. A lot of people are going to say pulses per second. You're going to see it written both ways. You might see you can see it on test. You might see it as frequency, or you might see it as pulses per second or hertz. Either one of those is fair game. And when you write your soap notes with these, you can use either of those two, whichever you prefer. So that's your frequency, the number of cycles per second. Okay, what is the pulse duration? Okay, so every electrical current is going to have a pulse. Okay, so let's look. Can y'all see where my mouse is moving now on the picture? Okay, let's say that this line up here is still representing 1 second. Okay, well, you see that you've got, and this is what we would call a biphasic wave or a balanced wave, because it's got the wave goes above the line, and then the second part goes below the line of charge. And then you can see there's a break where there's nothing on, and then there's another line of charge, and then there's a second line of charge. This would be this right here. Now, don't let me confuse you. I'm going to step back a second. From this point right here to this point would be 1 pulse per second, would be 1 wave. From here to here would be the second wave, because the waves, this is an alternating current, which means it goes on both sides of the charge line. And there's 2 wave pulses per second. Okay. So a pulse duration is the amount of time that 1 pulse lasts. So it may be called a pulse duration is how much time that 1 hertz lasts. It's all going to be measured in microseconds. So this weird looking cursive U with the S, that stands for microseconds. That's like way faster than a blink of an eye. Okay. So if you look where you say, and down below it says phase duration, a phase duration is just going to be half of the pulse duration. If you can see, you're going to have a phase duration on one part of the charge line where it's the pulse is going in one charge. And then when the charge goes down to the other, when the wave goes down to the other charge of the biphasic current, it'll be another phase duration, but together they make one pulse duration. Now, all of this, what I just said, sounds it's very foreign, and this is new to y'all. So y'all ask me questions. Did I lose anybody, or do I need to explain this differently? Because I'm glad to. So we're good? Everybody understands phase duration and pulse duration? Okay.
Yeah.
Am I speaking up? All right, we're good. Okay, very good. Okay, we're going through this. All right, time dependent parameters. We're gonna have an on for all, like, well, for muscle contraction, or let me not say that. Let me back myself up. For different types of stimulation, we're gonna have an on time of electricity and an off time. So this is where and it's exactly what you would think. It's the on time is when the electricity is on and going through the body and sending pulses per second. And then the off time is the rest time, where there's no train of pulses going through. If you look down at the bottom picture, you can definitely see that. You can see there, if we said this is 1 second here, oops, sorry, I didn't mean to do that. Back to this previous slide. This would be 1 wave, 2 waves, 3 waves. So you would have 3 hertz, and then, oh, I'm sorry, you'd have 3 waves and then an off time. And this off time, nothing would be happening. Okay, we'll explain why we need an off time a little bit later. There is a very good reason why we need an off time. Okay, now going back up to this next picture, all this means rise time and decay time. That just means the rise time is the time in milliseconds it takes for the power to go from 0 up to your desired intensity, and decay time is the time it takes for it to go from your intensity down to 0. That pretty much makes stuff, that's pretty much self-explanatory. And back to on and off time, usually we use this for muscle contractions only. So when we're using electricity for pain control, it's always going to be on. We're not going to have any off times but during muscle contractions, muscle strengthening, that's when we have the on and off times. Okay, so just during muscle contractions, we always express our on and off time as a ratio of on time to off time. So if you had your electricity on for 10 seconds, you could, I will tell you this, let me tell you the book rule, and then I'll tell you the real life rule. The book rule is that when you're doing muscle contractions, you keep your electricity on for 10 seconds. So your on time is 10 seconds, and then your off time is 50 seconds. So that makes 1 minute total. So that's 10 seconds on, 50 seconds off. So you can say that's a 10 to 50 ratio, or you can say that's a 1 to 5 ratio. Now, if you think about it, when you work out, if you are exercising, you don't contract a muscle, like say 1 time, and then wait a whole minute before you go into another rep. That's a long time to wait. You're wasting a lot of time and not much is going to happen. So think about this. If you're in a clinic with somebody and you're doing electrical stimulation for strengthening, and you have your off time for 50 seconds, you're barely going to, in 10 minutes, you're only going to get 10 single contractions. So usually what we do in the real world, we bring that off time way down. We might keep the on time for like 10 or 5 to 10 seconds. And that off time might be 15 to 20 seconds, much, much, much shorter. Because when you're in a clinic, you've got to maximize your time. And also, people that are getting this from muscle contractions, if their off time is 50 seconds, they get bored just sitting there doing nothing. So that's on time and off time. That's all it is. Okay. Ramp time, ramp up time and ramp down time. Another self-explanatory parameter, I think. The ramp time is the time it takes for the current to get from 0 to the maximal amplitude that you chose. That's all it is. And then the ramp down time is the time it takes for the amplitude to go from the maximal intensity down to nothing, down to the gradual stop. So if you're looking at this picture here where my mouse is moving, this would be the ramp time. You can see the ramp time right here going up this way, and this would be the ramp down time. So this would be some pulses, and then an off time, a long off time, and then several more pulses. And you use the ramp up and ramp down time for a few different reasons. One is for comfort, because if you just had the machine go from 0 up to your desired intensity all instantly, that would shock the patient, that would hurt, and it would also cause their muscle to jerk and they could hit themselves or kick you or kick somebody. But it's also done to make a gradual contraction, like a normal contraction, and then a gradual relaxation, because you want the muscle contraction to be as smooth and normal as possible. Might not be as fast as a normal person would be, but you want to make it a soft start, make it contract smoothly and in a good time, and then relax in a good amount of time too. So no more than a few seconds. And usually our ramp time is we set ramp up time, and we usually set that from 1 to 2 seconds. No more than 2 seconds is usually needed. And usually downtime, we don't even set that. The machine does that for us. Okay. So now we're going to talk about waveforms. We have a few different waveforms. We're going to talk about all of these. So before I go on, any questions in ramp time, on and off time, pulse duration, phase duration, any of that? This is the time to ask. Okay. I know this is deep, but the next 2 PowerPoints will be a little bit more exciting. Okay, so these are the different types of waveforms that we're going to go through. So direct current. We've already talked about direct current a little bit, but direct current, remember, if this line right here is the line of charge. So this is where positive charges occur. This is where negative charges occur. Direct current is a continuous flow of charged particles or electricity in one polarity, okay? So it's either going to be, direct current is either going to be a continuous, direct current is either going to be a continuous positive wave, or it's going to be a continuous negative wave down here. Okay, so like I said, we use iontophoresis mostly for, we use direct current for the most of the time for iontophoresis. Sometimes the alternating current is not going to be enough for a de-innervated muscle, so we have to use the direct current for a de-innervated muscle. And remember, that means a muscle that doesn't have a nerve connection. And for wound healing, we use direct currents too, because some currents are bactericidal. Alternating current is what we mostly use in everything we do. This is when you have it's an alternating current, and it's a flow of electricity in one direction. But if you look at it, the wave of electricity is on both sides of the line of charge. So sometimes it's going to be positive and sometimes it's going to be negative. This is an alternating current. this is what a lot of our household appliances work on. This is what a lot of our electricity grid works on, alternating current. Some things work on direct current, but a lot of things work on alternating current. And remember, this is going to put in an equal ion flow in each direction. So when the machine goes off, there will be no electrical charge left in the tissue. And most of the time, for everything we do, if we're working on muscle contractions, except for the innervated muscle, and then for pain control, we're using alternating current. We very rarely, not very often, do we use direct current. Most of the time we're using alternating current. Okay, pulsed current. Well, all a pulse current is, I'm not going to read through this with word for word, but all this says is that a pulse current is a current that is delivered in pulses, and it's not continuous. So you may have a series of, let me just think of something. You may have a series of 3 pulses and then a rest, and then 3 pulses and then a rest. Somebody got kicked out. Let me let them back in. Sorry, I went the wrong way. Okay, so I have like a certain number of pulses and then a rest, and then a certain number of pulses and then a rest. And the charged particles only move in one direction. But if you're using a biphase, and that would be if it was a direct current. But if it was a biphasic current, the charges would be moving in both directions, like this shows. That's all that means. It's all your pulse current is talking about, whether it's a unidirectional or bidirectional, and what kind of charge it is. Okay, and then this is what we call a unidirectional monophasic, because it's on one side of the line and it's going one direction. And this is what we call a biphasic pulse, because you can see it's going in one direction, but the pulses are on both sides of the line. So we can also call an alternating current a biphasic current. So you might hear some of us say do a biphasic current for pain control. That just means use an alternating current for pain control, and that would just be tensor IFC, because they're both alternating current. You couldn't do it, but you couldn't do it monophasic. So there you go. Okay. Now biphasic pulse currents can be symmetrical. They can be balanced symmetrical, or they can be unbalanced symmetrical. Now, I'm not going to go very deep into this, and this is not anything you're really going to set on your machine. This is just for you to know about polarities and currents, that some currents may put in a little bit more positive than negative charge. Some of them are going to be equal. Some of them are going to be equal, but different time amounts, and some of them are going to be completely unequal in their amount of charge. That's all that means. Symmetrical. You just remember balanced or unbalanced. Okay, I'm gonna skip this slide because we have a whole PowerPoint through that. Skipping we have 2 of that. Let's go to this Russian. Well, that's more in the. Okay, we're gonna skip these slides because these are more specific electrical things, and we're gonna talk about them in following lectures. Okay, but let me stop on Russian protocol. This is a type of electrical strengthening that was developed actually, and it's called Russian protocol because it was developed by the Russians during the Russian Olympic Committee weight training committee during like, I think it was like the 40s or 30s or 40s or 50s. Well, the Russians started using, and this is no lie, I promise, this is a fact. The Russians started using electrical currents during weight training to strengthen even more and to make their muscles even bigger and even stronger. Now, they use a 2500 hertz carrier wave. That's 50 bursts of electricity every second. That's a lot of electricity, okay? That's a lot of electricity. Our bursts are usually much, much, much lower than that. But that is a lot of electricity, and that would help them pick up or lift a lot more weight than if they were doing it on their own. Well, that's how they trained. And then I don't know if they got caught before the Olympics or not, but either way, those people were like bulked up and they obviously look way different. And I think now, I don't know if this probably isn't outlawed for training now. I don't know because it's so common, but it's called Russian protocol because the Russians were the ones that developed it. But now it's done all over the world now for athletes and for people trying to get back to sport. And not just you get back to sport, but sometimes in regular outpatient clinics, you may use it if it's more of a sports medicine type of clinic. But we'll talk more about Russian protocol when we talk about muscle contractions, okay? So don't worry about that for now. Okay, ions for iontophoresis. So when we were talking about using direct currents and applying the medications, which that's the only medications we can apply in our profession are these medications. So the first one, and you don't have, I do want you to remember these, but you don't have to know their polarity, okay? Dexamethasone is a steroid, and it can be given for anti-inflammatory reasons and to break up, can you be used to break up bone spurs and things like that. And the reason we would use iontophoresis instead of just taking a pill or an injection is because when medicine goes through your stomach and your GI system to get absorbed, certain changes take effect to it, okay? Well, when you put it on this medicine on a patch and put it on the skin and it's directly above the affected area, and then you push that medicine through the skin with electricity, it doesn't have to go through any of that digestive stuff. So the medication doesn't change at all, and it gets to the body area in just the way that it was meant to be. So that's a good reason we use iontophoresis. So dexamethasone is a steroid, an anti-inflammatory. Lidocaine, probably you all know that, is for from pain control, for numbing. And I think salicylate, if I remember correctly, that's also for, if y'all talked about heterotopic ossification yet in patho, if you haven't yet, you will. That's whenever a person has bone growth that starts either inside of a muscle belly or inside of a joint where it's not supposed to grow, usually in response to trauma. And salicylate can be used to break up some of that bone so that it doesn't grow any bigger. So you don't have to know these, don't worry about looking up the polarities, just know that these examples. Okay, contraindications. These are contraindications for all the electrical modalities we're going to go over. Now, remember, they're in a little bit more detail on your skill comp sheet, so go over that when you're studying for skill comp. But if somebody has a pacemaker, we definitely will not use electrical currents with them because that's keeping their heart going. We could give them an unstable heartbeat. We could put them into cardiac arrest. We could kill them, no lie. If they have an arrhythmia that's unstable, so if they have unstable AFib or an unstable heart rate, then we don't want to do this there too, but we don't want to use electrical stim on them because this could affect their heart rhythm. You don't want to place the electrodes where this says carotid sinus. That's right here over where where your carotid and your jugular go. Now, obviously, that would just be for, you would never place electrodes on the neck, in the front of the neck. So I would never want to see any of you putting electrodes anywhere around the front of the neck. Now, you can put electrodes on the back of the neck for pain control, but nothing in the front of the neck, because this is where inside of our carotid artery, we have inside the carotid arteries, one on each side, we have chemical receptors and we have pressure receptors that are inside of those. And those help regulate our blood pressure going up, not just to our brain, but to our whole body. So if you were to put electricity around that, that would stimulate those receptors, and that would completely throw off your autonomic nervous system, and your blood pressure and your heart rate would go out of whack, and everything would get messed up. Now, let me tell you the one time when this will be used on the neck. Speech therapists are specially trained to use electricity on the front, on the swallowing muscles, with teeny tiny electrodes to regain swallowing control, usually after a stroke. Because when you have a stroke, a lot of times you lose the ability to swallow safely. You might aspirate, or you lose the ability to swallow completely. So they actually help you get the ability to swallow back with electrical stimulation, but they have a very special place. They have very special places they put their electrodes. It's nowhere near the carotid, and they're teeny tiny electrodes. So they're the only people that never need to be doing this, not us. Anywhere where there's a blood clot, that's a thrombosis or a thrombophlebitis. Anywhere where there is a blood clot, or where they've had a history of a blood clot. And if the person is pregnant, you don't want to, you don't want to use it anywhere near the abdomen or the low back, but no questions asked. Never again, amen. You don't want any electricity going around an unborn baby. Now, precautions. If they have a cardiac disease, so not an arrhythmia, but maybe if they have, maybe not an unstable arrhythmia, but if they have a stable arrhythmia, you know that from their history. And if they have another cardiac disease, and it's not anything that has to do with their heartbeat or their heart rate, I would always, even if you think that it's okay, I would always call their doctor just to get clearance that you can do this. So even if it's just and you as the PTA can do that. You don't have to have the supervisor do that, or you can have the supervisor do that if you want to. But you could just call the referring doctor and just say, hey, I'm seeing this patient for this reason. He has a history of this cardiac disease, but I was interested in trying electrical stimulation for blah, 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 blah reason. Is this okay with you? Do you think this is safe? And the doctor will either say yes or no. You can't just make that decision on your own. If you have a doubt, you need to get permission. Impaired mentation, that just means cognition. So if it's a person that's very, very confused because of their mental state, maybe because of their mental illness, or in my case, in my treatment, not in my personal case, that sounds terrible, but but in my experience, in my practicing case, people with brain injuries and strokes are not always going to be completely, they're just not going to be all there in the moment. So it's not a contraindication to do electrical stimulation on them. If you can explain to them what you're going to try, and they seem to be okay with it, and the stimulation, they're going to feel the tingling, and it doesn't really scare them or make them too agitated, that's okay to do it on. Now, but if it's somebody that is so confused that you have to remind them every single minute what you're doing, you have to remind them of why they feel electricity, and if it makes them scared at all, or they're constantly asking you, what are we doing? What is this? You wouldn't do it on them, because they don't have the mental capacity to take part in that treatment. You want them to be able to do it, okay? If they had impaired sensation in that area, that's not necessarily a precaution, but remember, with all of our modalities we've done so far, we've always done a 5-minute skin check after we start. So with electricity, that's the same thing as what we do. 5 minutes after we've been going, we don't peel back the electrodes and look under the skin, but we just look at the skin around the electrodes to make sure it's not getting red. If it's not getting red or changing color or getting different colors or getting pale, then it's okay. If it's getting really, really red or changing colors or getting mottled, then that would be a time we need to take it off. Yeah. If the person has malignancy in the area, or they have a history of malignancy in the area, I wouldn't do it, because you could spread it. You could spread the cancer to even more places if it hasn't spread yet. But it would be a precaution if this person, say, is terminal and they're in stage 4, and let's say you're doing home health and they're in hospice at their home, or they're in hospice in a facility, and let's say they're having a lot of pain. Let's say they have a lot of back pain. Even though they have malignant cancer and they're in stage 4, it would be medically okay to do electricity on them then, because it's for pain control. They're in hospice to go comfortably and to die in dignity. So we don't want them to be in so much pain. And also, no family wants their family member to be drugged up in hospice on pain meds to where they don't even know what's going on. So a lot of times, people in hospice will use TENS or interferential current for pain control to help with pain relief, so that they don't have to be on pain meds, and that can help a lot. So that would be one of the only times you could use it with somebody that has a malignancy. And as always, any skin that has a skin irritation, like a rash, an open wound, a bruise, you wouldn't want to do this over that. No electricity over those. Adverse effects that could happen. You could burn the skin. Now, that's not very common, but it can happen. That can happen when I told you that the electrodes are sticky. They have a sticky gel on them that's conductive, that will conduct the electricity through the gel to the skin. And we can use those electrodes on the same patient over and over, but only for a certain amount of time. Now, after they start losing their stickiness, they lose their conductiveness, and then that could cause a burn on the skin. So that would be, if it's losing its stickiness and its conductiveness, the electricity is not going through the body, it's just staying on the pad, and it would cause a surface burn. Okay. Also, where this says use 2x2 or 2x4 electrodes, all that, and that says for IFC, that forget IFC, this is for any electrical current. The bigger the electrode, the smaller the risk of burning and the more comfortable the electrode. The smaller the electrode, the bigger the risk of burning and the more they're going to feel a stinging. The person, it is possible to have an allergic reaction to the adhesive that's on the pad. So if you did electricity with them one time and then they had enough reaction to the pads, that might not show up until after a few hours after they leave you. But that's why you need to tell your patient to look at that area, because if they're allergic to the gel on the pads, then we need to think of another way. There actually are water electrodes with sponges that we can use, that are old school electrodes, and we can use those. And we use it for pain. I'll try usually try using and this just means try using you start off at your lowest amplitude that you need. Don't just, if you're in pain, you don't want to have your patient turn the machine up as high as they can take it. You want to start at low amplitudes. That means low, the patient will feel just a little bit of current that's comfortable that they can take for a long period of time, like 30 minutes or so, or in the case of some TENS, up to 24 hours. And remember, the bigger the electrode, the less risk of burning, but also the bigger the electrode, the more comfortable the current will be. The smaller the electrode, the more dense the current is, and so it makes it more painful. Okay. After this, we're almost done with this PowerPoint, then we'll take a break. Patient positioning. Obviously, this is just going to be dictated by the area you're treating and your goals and the device you're using. You know, if you're doing something where you have to drape the patient, keep them comfortable and modest. Electrode type. Mostly, we're always going to be using the disposable, flexible, self-adhesive kind. That's the most common out there in the market and that you'll see in books and stuff. The old kind that were the old school electrodes that we still have some examples of, I'll show you. They were actually just a piece of carbon and they have silicone rubber mixed in with it. And then you actually take a sponge, a wet sponge or a special kind of gel, and you put on that, and then you stick the wire into it, and that conducts the electricity. So that makes me a little nervous with mixing water and electricity, but it is the way they used to do it, believe it or not. Size and shape of the electrode can be more comfortable. The bigger it is, the more comfortable it is. Electrode placement. You always want to avoid wrinkles and gaps in the skin. So when you lay down a pad, you want to make sure you take the wrinkles out in the skin. Don't let there be a fold in the skin or a wrinkle. You want to pull the skin taut with your other hand. You want to try to stay away from bony prominences as much as humanly possible. Because that's just not going to be comfortable. Think about it. If you put it right over your greater trochanter, that's not going to feel good after a few minutes because the trochanter is so superficial. If you put it on your olecranon, that's just not going to feel very good after a few minutes. It's going to sting a lot. Also, the spacing of your electrodes affects different things. So look at these two pictures. If you have your electrodes closer together, the current is still going to go down into the tissue and spread, but look how deep it goes. Now look at the second picture. If we have our electrodes a little farther apart, same exact electrodes, same exact settings on the machine, but we just spread our electrodes apart. Now the current is going to go down deeper into the tissue. So that's important because if we're going for pain relief, we might want to cover as big of an area as possible. Or if we're doing a muscle stimulation like the quads, we want to have one electrode way up high by the top of the thigh, and then one way down below at the bottom, right above the patella, because we want to get that electricity going through the whole quadriceps group, not just through a few of them. So if you put them real close to each other, you're not going to get a very good contraction. And thankfully, that is all of that lesson. So I'm going to pause, resume recording. You would think by now I'd be a Zoom pro, but I am not. Okay, talking about TENS. Now I can't get this out of the way. Okay, still on electrical currents, and we're talking about TENS. TENS stands for transcutaneous, so through the skin, electrical nerve stimulation. So obviously it's a pain modality. So TENS is what we use for pain control. So if you've seen, you might have used to, you could only get you had to get a prescription to get a TENS unit. And usually doctors would write a prescription form, and then therapists would give them out. Now you can buy them over the counter. And you can buy them on Amazon. I've seen them in Target or in the drugstore. The only problem with that is, the problem I have with that is the kind you can just buy over the counter. There's no skill involved in that. So all you're doing is sticking pads on you and putting electricity. Like, you don't know, that machine is not set up for different parts of the body. It's not set up for different types of pain. It's not set up for different areas. So it's not going to be, they're not the best. Now, I'm not going to dog them completely. They do have their place. If somebody has just a little back pain, they want to keep it forward, then that's good. If they don't want to have to go through insurance and stuff, they have to get an expensive one, because they can get expensive. But they all work basically the same, to be honest, though. TENS works on the gate control theory of pain. So we're doing that because we are stimulating noxious, well, what we're doing, we're taking the stimuli from the electricity and we're stimulating the transmission cells at the spinal cord level, and then the noxious stimuli that we feel, the pain, we don't feel anymore. Now, I got a little ahead of myself here. This says noxious stimuli are transmitted from the periphery along A deltas and C fibers. You knew that. Okay, so these are some settings that if I were you, I would star this slide, highlight it, write it down, make a big poster in your room and hang it up and know it forever. At least one of them anyway. You're gonna have more. So conventional TENS, and this is what we would call either conventional TENS or high rate TENS. So there's high rate TENS and there's low rate TENS, okay? Conventional TENS is the same as high rate TENS. You'll see it, you'll use it interchangeably. Don't get them confused. Okay, so we talked about pulse durations earlier. Well, when we use TENS, usually we're gonna, with high rate or conventional, we're gonna keep our pulses set to 50 to 80 pulses per second, okay? And that's the setting you'll do on your machine. Your pulse frequencies will be your other choice that you can choose. You're gonna keep the frequency between 100 to 150. Now, obviously, you want to start off on the lower end of those spectrums, and because we always want to start off with the lowest amount of electricity that we need to give in order to get the pain control. The current amplitude is just the amount of power that you're going up on. So you're either going to be turning a round knob or just hitting the button going up. You want the sensation, they're going to be able to feel the electricity. You want them to feel a comfortable and tingling sensation, almost like that body part is going to sleep, kind of like when your foot falls asleep, or it's going numb and it's kind of tingly, or it feels like ants crawling across their skin. That's what we want them to feel. We don't want them to feel shocked. We don't want them to feel any biting or stinging. We just want them to feel that tingly feeling. Now, it needs to be a strong tingly feeling, but still comfortable and tolerable. It does not need to be painful at all, because the whole point of TENS is to get rid of pain. So we don't want to cause more pain. You can use TENS when a patient is in pain. You can use TENS up to 24 hours a day. There's not much of a, I mean, you do need a break after this. Now, you can't use it when you're sleeping. You can't use it when you're driving or when you're bathing. So obviously you couldn't use it 24 hours a day, but even if you wanted to, but if somebody was in a lot of pain and they say they had a major back injury and they were like down in the bed for days, they would probably keep a TENS unit on for a long time, hours at a time. And what this will do, this also interrupts that pain spasm pain cycle we talked about earlier in the semester. This will interrupt that too. High rate TENS. So know those numbers for conventional TENS. Okay, this is still on high rate TENS or conventional. It's usually what we call it's modulated to prevent adaptation. So what modulate means is that, look down at the very bottom bullet. It says modulation can occur with most of the parameters, the frequency, the pulse duration, and the amplitude. Well, we're not changing those. We set those at the beginning of the session, and then we leave them for the duration of the session. What the machine itself is going to do, and all the machines that we do this, TENS, IFC, and for muscle contraction, they have a setting that's called modulate. Now, some of them, they'll be called sweep. Some of them, it'll be called modulate. It means the same thing. What you do after you find the comfortable sensation for the patient, you set the machine, and it'll be either be a switch that'll say modulate or M, or it'll be a button that'll say sweep or modulate. You just hit that button or hit that switch, and then you're done, and you let them go. What that's going to do is the machine is going to make gradual changes in the frequency, the pulse duration, and the amplitude than what you set. It does that because if you kept the same electrical current going through the body with all the same settings, the nerves are going to eventually adapt to that stimulation, and then it won't work anymore. So then the machine will be going, and they might feel the machine going, but it's giving them no pain relief, or it won't be giving them any muscle contractions or something like that. So when we find our settings on the machine that are just right for that patient, we always want to set it to modulate, or what's called on some machines sweep. They mean the exact same thing. Okay. So we don't adapt to the tissue. Adaptation is just a definition of that is decreased excitability of the nerve membrane with repeated stimulation. So lots of stimulation of the same type of electricity will cause the nerve to just tucker out and not even contract, not even send the action potential anymore. But if you are constantly changing it, and it's not changing it a lot, it's just constantly making minor adjustments, it's like it fools the nerve and it never will accommodate. Okay, so this is just an example of a modulation. You can see this. There's an example where the current amplitude was modulated. So you can see over time the current went up and down. You can see in the second picture the frequency was modulated. So sometimes the waves are coming farther apart. Sometimes the pulses are coming closer together. And then sometimes the duration of the waves is modulated. So you can see that some waves are going to last longer than others. So all three of these things are usually modulated just very slightly by the machine. And that's very important. Okay. Electrical stimulation helps us release our endogenous opiates that we have, that we make inside of our body. They act like, and we talked about this before a little bit, they act like morphine, and they bind to opiate receptors that we have in the brain to decrease pain. And they also act, and also our endogenous opioids activate, well, let me say this, repetitive stimulation of a nerve fiber, of a motor fiber, or in a delta fiber, produces repetitive muscle contractions or little bitty sharp pains. Well, why would we want this to happen? Okay, let's back it up just a second. Okay, so we all know that we have endogenous opiates that we can release in stimulation in response to pain. Okay, if a motor nerve or a nociceptive A delta fiber is being repeatedly stimulated by electricity, then we're going to have to do, it's going to be called low rate TENS. And that's when the muscle, and this is still for pain control, this has nothing to do with strength, but this has to do, we need muscle contraction to happen with this type of pain control. So, but it's a very small muscle contraction. It almost looks like, if you were looking at it, you have to look down at the skin. It's not going to be a regular muscle contraction where the joint moves. It's going to look like an isometric contraction, an isometric contraction, but even less than that. It's going to look like there's little waves or ripples going through the muscle. You'll actually see ripples or waves going through the skin, or like you'll see little bitty parts of the skin jerking, but not like a full muscle contraction, but just a little bit. That's what you want with low rate TENS. This low rate TENS is also called acupuncture TENS, okay? Because this requires longer pulse duration, so the electricity needs to stay on longer, and higher amplitudes of electricity. So we do use a lower frequency for low rate. That's why it's called low rate. So we use 2 to 10 PPS. We only want those big waves going through. And what we do, you only want to keep it on there for no longer than 45 minutes at a time. So it's different than high rate. But this can control pain for 4 to 5 hours after the machine is removed, because we have released opiates. So how did we release those opiates? Let's go back to the previous slide. So we had it on low rate. We've got 2 to 10 pulses per second, which is very slow. And then we're going to have a higher amplitude. Well, if you go back and look at this one, electrical stimulation releases endorphins and enkephalins. If you stimulate a motor nerve repeatedly, then you're going to get those little muscle contractions I was talking about, those little flutters. Those little flutters or little waves in the muscle, that is what is releasing the opioids, okay? So in this case, it is the electricity, but it's the small flutters in the muscle that are releasing the opioids. Now, it's not like a full-on muscle contraction. It might only be just like a minor jerk, like you might just see the muscle jerking just a little bit, or just twitching. If it's just a twitch, that's okay. That's all you want. You never want a full muscle contraction. But this would be, the frequency would be from 2 to 10 pulses per second, and the amplitude would be set much higher. And your pulse duration would be set much higher too, maybe up to around 150 to 200. Okay, this is just, we'll talk just briefly about burst mode TENS. Sometimes this is better tolerated by people. This just comes with it just comes by like a few bursts of electricity followed by a long off time. It's just more of a rest for people if they can't take it continuously. But I've rarely had to use burst mode. Most people will take it continuously without a break. Okay, so how do we know where to place the electrodes for pain stimulation? Well, it's not going to be along the motor points as in motor control. It's going to be along either acupuncture points, which, hello, none of us know those, or it's going to be really where you're going to put it on is you're going to surround the area of pain. So what you're going to do is ask your patient, where is the center of your pain, or where is your pain radiating from? Now the pain might be a big area, but if it's radiating from one area, that's the area you're going to surround with your electrodes. And you'll either have 2 or 4. And in TENS, you always have 2 electrodes, only 2. So you surround the area of pain with a few inches on either side, trying to stay away from bony prominences. And then you turn your electricity up a little bit. And then you turn the amplitude up just until they feel a comfortable sensation. And then if this is for high rate TENS, they should feel just a comfortable tingling, but no muscle contraction. If they need low rate TENS, where you want the pain relief to last a lot longer so they can have their opiates released, that would be where you have 2 to 10 pulses per second. Okay. And then yeah, that's about it. Where this says electroacupuncture is gaining therapy, that has a lot to do, that's like dry needling with electricity, where they'll, and most of you know what dry needling is, where therapists will take needles and stick down into trigger points. You can also take electrodes and clip onto those needles when they're in the skin, and it will help, and it will cause a lot of muscle twitching to go on, but it'll help with pain control and trigger point release a lot too. I already talked about setting up your electrodes to surround the area of pain using 2 channels or 1 channel. This is just say 2 electrodes, not 4 electrodes, 2 electrodes, because this is for TENS. You're just going to intersect over the area of pain. You don't want the electrodes to be right over the area of pain, but just going, you want the line between the electrodes to be going through the area of pain. And you want them to be no closer than 1 inch apart from each other. If they're and that's probably going to sting a lot because they're close. You need to space them out so that it'll be more comfortable for the patient. Okay. This is all of your TENS settings for high rate and low rate. Everything you'll need to know. So highlight this slide, copy this slide, write down this slide, put it to memory, everything. So, but it does mix things up a little bit. So look, if this is your parameters for pain modulation. If you want high rate, and you got to jump back and forth here. This is just This is just pulse duration. This is just frequency. Biphasic, conventional, high rate TENS, which is the one that we can only keep on for no longer than 45 minutes. I'm sorry. Yeah, no longer than 45 minutes. You use that you start off at 50 pulses, 50 hertz. I'm sorry, 50 pulses per second. 50 to 80 pulses per second are hertz, and you would set your frequency between 100 and 150 pp's or hertz. So this is your pulse duration or your phase duration in microseconds. This is your pulse duration. Oops, sorry. This is not pulse duration, sorry. This is your frequency in hertz. So on your TENS machine, you would have frequency, a place that said frequency, and then you would have a place that said pulse duration, and you would set the knob to go to 100, and then you would set the knob at 50, and that's where you would start for high rate. And then you would go up on your amplitude, and if you just can't get anything comfortable or that's helping them, then you can go up on your pulses per second or your pulse duration, and then that will usually get better results. Okay, now if you're doing low rate TENS, which is the one that releases the endogenous opiates and is the one that makes the muscles contract, have a little flutter, and the one that gives longer pain release, you're going to have that pulse duration set for a lot longer than high rate. You're going to have it set on low rate from 200 to 300 microseconds. So a lot longer. But look at your frequency. You're going to be less than 10 pulses per second. So low rate and high rate are named for their pulses per second, for their frequency. But just remember, high rate has high pulses per second frequencies, low pulse durations, where low rate has low pulse durations, but high frequencies. So they're completely the opposite of each other. So you do have to know that, what I just told you, and you do have to know these numbers by heart, because you will be tested on them. And in practical and in skill comp, we won't let you just choose a range. We're going to make you choose a number in this range and stick to it and try it. So this is the slide for knowing high rate and low rate for tens. Put it to memory. Just a little bit more. We've already talked about this a little bit. Conventional high rate tens, you just want a comfortable, gentle sensation. They should just feel a tingling. And with low rate and burst tens is the one you want the visible muscle contraction, but not a big muscle contraction, just the waves or little twitches under the skin. Okay, conventional or high rate tens you can wear as long as they need it, up to 45 minutes. And low rate and burst tens you can only wear for 20 to 30 minutes at a time, and no sooner than 4 hours in between. Okay, so before we go on to interferential, do y'all have questions about tens? Because there's a lot of settings, and we used a lot of the words from the last lecture, but any questions on tens? It really will make a lot more sense, guys, when you get in there and play with the machine. So if you can come to Open Lab this Friday, we have 4 tens machines, but then the big ultrasound units can also do tens and IFC. So we can practice on those, and I can show you before we even have the lab on these, how to do those things if you come in on Friday, and how to change those things. Once you start seeing the machine and then you'll all be given a set of your own electrodes that you have to keep up with the rest of the program. Once you feel you're doing this on each other and you feel it on yourself, it makes low rate and high rate it clicks, and it makes so much more sense. Okay, so it might be about clear as mud right now, but I promise once you get in the lab and try it, it will be clear or clearer. Okay, so but on that note, any questions on tens? So there's high rate and low rate tens. Okay, y'all are either super smart or just scared to death to ask a question. Okay, so let's stop looking at tens, and we have one more, and it's going to be interferential current. And this one is very much like almost the same as tens. It's a shorter PowerPoint, a little bit easier to understand. Actually, if you can do tens, you can do IFC, because there's not much setup to it. Maybe I should have went over IFC first. Okay, IFC stands for interferential current. Okay. This is delivered through 2 sets of electrodes, or 2 pairs of electrodes, or 4 electrodes. So with tens, you almost always, tens that we were just talking about, you almost always just use 2 electrodes. Now you can use 4, but it's not very common. But with interferential current, you always use 2 sets of electrodes, or 4 total. And it will be 2 wires, 2 going, 1 set of wires going to two electrodes, and then another set of wires going to the other electrodes.
I don't think you're sharing your screen.
Oh, I'm sorry. I thought I was. Sorry. Escape. Thank you. Y'all see it now?
Yes.
Yeah.
Okay. Sorry, y'all have to keep me accountable for Zoom things. So interferential, like I said, you're using 4 electrodes and 2 wires. And what we call those wires channels. So in tens, we may say we're using 2 electrodes and 1 channel, but when we use, and channel just means how many wires you're using. With interferential, we use 2 channels because each channel has 2 electrodes on it. And that'll make more sense when you see them in the lab. Okay, electrode placement, we're gonna jump right into that. Well, since we have 4 electrodes, we're gonna, remember with tens, we wanted to surround the area of pain. And it's just the same as an interferential, except now we have 4 electrodes. So we're gonna make a big square around the area of pain. So interferential is good because we can, it's good because we have 4 electrodes and we can cover bigger body areas with 4 electrodes than with just 2. Now, I'm not going to say that's always going to be the most appropriate case to use it. Some people might just prefer interferential and some people might just prefer tens because of their comfort. And we have to do what they're comfortable with. But tens, interferential is good for bigger areas. But what you do, let me see if I can get in the next slide. Yeah. I'm gonna let me read through the slide and then I'll explain it on the next picture. So you've got 2 alternating currents, 4 electrodes, and you want your currents to intersect with each other. And that might sound a little bit dangerous at first, like why would I want 2 electrical currents to intersect in a person's body? That might hurt. It doesn't hurt. What it does is it causes what causes what we call a beat frequency. So what it is 2 and let me go to the picture. So look at the colors. The blue wire and the blue electrodes, those are 1 channel and they represent 1 wire, and that 1 wire is hooked to each blue electrode. Well, then the number 2, the red wire, is hooked up to 2 other electrodes. So, and we're going to say the center of pain, you always want to place the electrodes, you always want them to intersect their electricity right in the middle. And electricity tends to take the path of least resistance, so usually straight lines. So it's going to go in a straight line. Well, at these 2 electrodes are going to send a current between each other, and so are these 2. Okay, well, in the middle, at the center of pain, where those 2 electrical currents meet, and the machine is going to keep those currents slightly different so that they don't cancel each other out, that's going to cause what we call a beat frequency. That's what we want. That's what's going to cause the pain relief. Okay. Don't worry about carrier frequency. Okay, so more about interferential. Let's just go back to that picture again. So it is 4 electrodes and you are actually crossing 2 separate currents. So, you know, and let me tell you this difference. If you were doing tens and you wanted to use 4 electrodes, you would not have it set up in this manner. You would have it set up with, say, number 1 here and number 1 going in this direction, and then number 2 here, and then number 2 here going parallel in a current. And you would have 2 parallel currents, and that would help the pain. But the best way to help a way of pain is to have interferential, because Usually you have to use a lower current amplitude, so it's more comfortable for the patients. It delivers more total current than pulse tens, and studies indicate that more pain relief can come with this setup than with tens. Not every time, but studies do indicate that IFC, interferential, does tend to give a little bit more pain relief than tens. Now, but the thing is, interferential machines are not for home use. They're big. They're only for clinical use. There's not any on the market you can take home and buy. So people can only buy tens machines. You only use an interferential machine when you're in the clinic. It's going to have a pre-modulated current. Pre-modulated means everything is set up for you. So I'm going to make you all happy here. All of those settings you had to learn for tens, for high rate and low rate, they still apply for interferential, but the machine sets it up for you. You only have to hit the button that says high rate or low rate. So in interferential, there's almost no way to fail this skill comp, because we're telling you the type of pain relief they need. We're telling you the area it is, and you know that with tens, you only use 2. You keep, and if you use 4, you keep the lines of the electricity parallel. If you're using IFC, you always cross them every time, no matter what. Always cross. Okay. So this would be one pre-modulated current. And this is an example, and this would be one pre-modulated current that is on its way to hit another current. Now, this is an example of an IFC setup just on the lower back. You can see there's 4 electrodes on his lower back, and they're crossing, and they're crossing right in the middle of his spine. So the electricity is forming an X pattern on his back, and they're meeting right in the middle of the spine. So that's I can tell by where his electrode placement is, that his pain is in his lower back. So that's where his is. That's all on IFC and tens and everything. I know it was a lot of information because this is totally different than anything we've been talking about. But if you read over if you look in your textbook explains the basis of electrical currents and things very, very thoroughly, maybe a little too thoroughly, but I would make sure you look at that just to make sure you understand it and fill in any gaps that I might have left. And then look in the book about tens and IFC. IFC is fairly easy, but you really got to understand tens first to understand IFC, because they're pretty similar. The settings are the same, except the way you apply it is a little bit different. Please, if you watch the videos that I've got posted in Blackboard, and the mock skill comp videos that we have on our main PIMA YouTube page, you can see how it's done. And it's really not as bad as it looks, okay? And it's really not as hard as it looks. It seems the hardest thing in the beginning is learning your settings for high rate and low rate. But after you know that, and just know that they're opposite of each other, it's fairly easy after that. You have a lab sheet that goes along with this, so please get that lab sheet out, and it's got a lot of good information, and it puts it together for you pretty well, a little bit better than my PowerPoints did. It kind of condenses it all together right where you need it, all your contraindications, how many electrodes to use, all those kind of things. So we got 30 minutes, question time over any of the lectures we went over. I heard something, but it wasn't clear. Did somebody have a question? Okay, maybe not. Maybe I thought I heard something. Okay, so that's all for class today. So remember, practicals start Monday morning. I mean, not Monday. Scaring out of death. Wednesday morning. I think since by the way I've seen y'all practicing and in skill comp performance, I think y'all are ready. I know y'all are nervous because this is your first big practical, but don't be too nervous. We're not there to scare you, and I think y'all are all going to succeed because y'all have been on top of skill comps. Y'all have been on top of these contraindications and your everything. I mean, we haven't had to hold your hand very much like the other cohorts. So y'all are in a good place. You know, watch the videos, practice with each other between now and then as you can if you get together. Send me questions and look over videos and everything. Any questions, any practical related questions right now? You all have your times and your partners. Please make sure, you might not have known this, make sure you show up 15 minutes before your scheduled time, because that will be your preparation time. So the time that's on the schedule is the time that you and your partner will start testing. So show up 15 minutes prior to your preparation time for us to give you your scenario so you can prep. And you'll get that prep time will be for you to write your contraindications down and get your modalities and stuff ready. And remember, everybody will have ultrasound for sure. And then you'll either have one cold modality or one hot modality, one or the other. And we tell you what to do. So we help you out. All right, I'm not getting questions, so y'all must be in good shape. Or you're just tired of listening to me.
I guess the questions come after, like once you actually like see it happening, I guess.
Right. This will all, it makes a lot, you'll all have a lot more questions when you start playing with the machines. That's whenever the questions start coming. And that's really the best time to learn. Like, I don't like teaching about electrical currents and stuff like online. I like doing it in person because it's just so much easier to teach it as I'm going, but we have to do it different because of COVID, but I think y'all will pick it up in no time though. It's a no-brainer. So it just takes a little bit longer to play with. If anybody has ever done electrical stimulation before, I mean, had it done on you and you know that you don't like it or that it just is obnoxious to you and it hurts you and you can't stand it, please let me know, because I don't want to do that to you. So I'm not going to torture you. So if you've had it before, you don't like it for sure, you don't, let me know and we won't practice on you. But if you've never had it before, please practice on yourself or have a partner practice on you at low amplitudes. Just get the feeling of it, because remember, if you're going to be doing this on your patients, you need to know what it feels like yourself. So don't be scared of it. Everybody's going to be a little weary just because it's electricity and then you feel tingling, but nobody can be killed by this. Nobody's going to be electrocuted. It's not going to make your hair stand up or anything like that. So they're just AA batteries, guys. They're not that strong. Okay. Any more questions? Last chance.
Mr. Allen.
Yes.
Isn't for PTA techniques, it's for kinese. There still isn't a submission for the chapter 4 homework.
Oh, I thought I did. I'll do that right now. Is there one for the other one? Is there one for the chart?
Yes, there is.
Okay, just not the other one. I'll do that right now. Thank you.
Thank you.
But for the chart, we only complete the first 3 columns, right?
Just complete the first 3 columns, because that last part to y'all we're gonna go over that last part in class.
Okay, so just don't turn it into it.
Yeah, that second part will be a second homework assignment.
Okay.
But we're not there yet, so I can't let you do it yet. All right, guys, if y'all don't have any questions for me, y'all are free to go. I'll stay on until everybody's gone.
Thank you.
And test review at 12:15 if anybody wants to.